عليكم السلام ورحمة الله.
الحقيقة this is not a lecture for 2 p.m. لكن I know it's a boring lecture, especially after Dr. Bander interesting lecture about ECGs. I changed the title because in fact nomenclature is one of the steps that you go through in a quest for quality. To improve quality, you have to go to many steps. One of them unifying the nomenclature of congenital heart, and then developing a database, and then risk stratification, and then validation. Can you start the poll questions, Abdulmalik?
Okay. Now we're starting poll questions. Please, everyone, answer these questions.
ما شاء الله. شو الحركات يا أستاذ ملك.
طلع لكم البول شباب؟
ما
أيوة
في شيء طيب. كويس.
أنا cannot vote عبد الملك. ليش؟
عشان الكو-هوست.
أها.
شوف الآن.
أيوة.
أنا عبد الملك ما طالع، ما في شيء طالع عندي.
هو بعد ما هم يصوتون دكتور.
طيب لو خليتني معاه. أوكي.
هي ممكن تقدر تشوفها في أحد من الخيارات اللي موجودة عندك تحت. أنا ما أدري بالضبط كيف راح تطلع عندك. بس الواضح عندي الآن إن 6 من 27 اللي صوتوا. ننتظر الباقيين.
الملك هو ما يطلع مين اللي صوت صح؟
لا ما يطلع.
لا ما يطلع عشان تعطي الناس كمان.
لا ما ترى ما يطلع، بس نحتاج التصويت عشان الدكتور.
أي. يلا شباب طيب. نكتفي بالموجودين.
I think so.
يلا عبد الملك.
طيب.
يلا عبد الملك.
يلا ثواني دكتور.
What's the result?
So I will share the result now. So for the first questions, what is the currently used nomenclature system in congenital heart disease? 17% answer the first answer, European Pediatric Cardiac Code. 67% for the STS Pediatric, and 70% for the IPCCC. For the second question, do you know the world database of congenital heart disease, heart syndrome? 8% answered yes, 92% answered no. For the third question, what is the current risk score for your hospital is using? 8% answered the Aristotle, 50% with the risk adjustment in congenital heart surgery, 42% for the STAT score. For the fourth question, which of the following is benchmark operation? 25% for the aortic arch repair, 17% for the DKS, 17% unifocalization, and 42% with the Fontan.
Good. Good. Okay. The right answers will be for the first question, what is the currently used nomenclature system? In fact, it's the International Pediatric Cardiac Code, the choice number C. You said how many they are using databases, Abdul Malik?
How the second question you mean? 8%.
Yeah. That's good. What is the current risk score your hospital is using? Now, currently, STAT score is the most commonly used or most widely used, adopted among the world, rather than United States of America. What is the current? What is the following is a benchmark operation? Only Fontan is a benchmark operation. The others are not a benchmark operation. And we will talk about this in the coming. So when you want to develop a risk stratification system for a quality measurement, you start with the nomenclature. We know that in congenital heart disease, we call, for example, perimembranous VSD. Some they call it membranous, some they call it subaortic. So there is no unified system. And during 80s and 90s, there were two schools, Van Praag School in the United States and Bob Anderson in the United Kingdom, or European, because Anthony Becker also from the Netherlands were also involved in the developing the European school. But we need to have a nomenclature, and this nomenclature should be linked to a coding system. And then we should have a database or a registry. And then after that, after the registry, which should be simplified, we should have a risk stratification. And we mean here risk stratification is not a quantitative measurement risk score like a Euroscore. It's in fact is some sort of grouping different operation or grouping different patients into certain risk category. Almost like a DRGs, if you know it, in billing the patients. And then validation process, we will not talk about it because time. And then collaboration between medical and surgical subspecialties. And then we should have a mechanism to obtain a longitudinal follow-up. The first atlas was developed by Abbott in 1936, and then it took 50 years till the Royal Brompton Hospital developed their diagnostic code. Almost more than 500 items were examined, classified, and given 6-digit code to each diagnosis. And then have been expanded by Anthony Becker in Netherlands to more than 1,700 items. And in early 90s, because of 70s and 80s, the people get used to do more operations. Then post-surgical new condition developed, and this resulted in a new need for a new classification. The European Pediatric Cardiac Code started in 1998 and then finished in 2000. At the same time, the STS and EACTS developed their own system, the surgical part, because the first European Cardiac Code is a cardiology-dominated system. So the surgeon and Revenge, they developed their system, but they soon realized in 2001 that we need to develop a joint program, and this have been established in 2005 in the World Congress in Argentina. And this is what we call it, they developed the International Society for Nomenclature of Pediatric and Congenital Heart Disease. And this lead to what we call it IPCCC, what International Pediatric and Congenital Cardiac Code. And it had many working group. One of them is nomenclature group attached every definition to a certain, give it a name, and the definition group, and then archiving group. And in the archiving group, even you as a pediatric cardiac surgeon or cardiologist, you can send your videos, images to them, and it will be there in their archive. And this is their site. You can visit at any time. And there is a cross map between ICD-11 or SNOMED also with the IPCC. And if you go there, you'll find more than 7,000 items attached to 6-digit code. And there are 2 versions for it. The European Pediatric Cardiac Code version or STS EACTS version. This is their site. And these are the versions that you can download. And this is the ICD-11 match with the STS diagnosis. If you concentrate on the 4th column, you find 6-digit number attached to each situation, even a normal. If you see the 4th or 5th row, there is a levocardia, which is normal, attached to 02, 01, 03. So everything is given a description, and by the end, the patient will have a group of 6-digit number, and this group will give a final diagnosis that go into the database. This also cross map to the ICD on a different level, from level 0 to level 7, and this will give you any one of you interested in congenital and he want to develop his own database, he should know the basic of this before that. That's the end of nomenclature. Now we have since 2014 almost a complete nomenclature. It took around 15 years to reach this stage. Then databases, it started with the STS congenital database immediately after the adult in mid-1990. And then the European, they developed 2 databases, depending on the association. And then the Society of Thoracic Surgeon and the European, they made what we call it International Congenital Heart Surgery Nomenclature Database that we described. It developed in, the idea started in 1998, but it was started on practice 2005, and 2014 in the World Congress in South Africa, it was the final format for the database was established at that. I will not go too much in the databases, but I want to talk to you about the European database, and you can register for it. And also the STC database, you can, recently they started to accept an international affiliation with the STS congenital database. But currently the World Society of Pediatric and Congenital Heart Surgery, they developed the world database, and I encourage every unit to join it, especially if you have a medical coder and database personnel that can put your database, your values in the database, and they will generate for you a report at least twice a year. We will go now from databases to complexity scoring. We have a different scoring system. Aristotle scoring system, which is a European scoring system, basic and comprehensive, and the RACS score, which is quite well known for those who get trained in the United States or Canada, and then a STAT score and category, which is the most recent, in which it joined the Association of Thoracic Surgery, STS, with the European Association of Cardiothoracic Surgery, and it's the most widely adopted at international level. The risk scoring modalities in congenital is very difficult, and I want you to see now, if around 70% of adult cardiac surgery fall into 6 STS categories. In fact, there are 4 operations: CABG, AVR, mitral valve replacement, and mitral valve repair, and the combination of them give you 6 categories. These 6 categories operation, or 7 categories, 70% of adult cardiac surgery fall in it. But when you go to the STS congenital database, you'll find around 135 operations, and in some databases even the last Aristotle Academy, it's around 235 operations, 37 operations. So we have a lot of operations. To group them into a risk, it becomes very difficult task and took a long time. The Aristotle score was based on only experience, opinion of experienced surgeon, and it was not based on statistic at all. And then it gives a complexity score to different category, around 5 category, and mortality depend on the complexity score from less than 1% for complexity score category 1 into more than 20% in the category number 5. This is the Aristotle basic score. If you go to this, and this is the Aristotle Excel sheet, you can download it easily and work on it in your own unit. And there is, after that, they realize that Aristotle basic score is not enough, and they developed what they call it a comprehensive Aristotle score, in which give procedure-dependent factor. We know that arterial switch operation is arterial switch operation, but arterial switch operation in a patient with a usual coronary pattern is different from a patient with a single coronary artery. So this is a factor, an anatomical factor that can be taken into consideration. A procedural independent factor like general factor, a patient coming for emergency operation, or a cachectic patient, a patient who is having anasarca, extracardiac factors, syndromes. We know that AV canal is an AV canal, but the risk should be different from a normal kid to a Down syndrome to a heterotaxy. So all these are the issues that should be taken into consideration. Surgical factor like a redo operation or a patient with a morbid obesity, all these can be taken into account. This is Aristotle Academy. You can, or institute, sorry, you can join it. It's free to join. And then we go to the American system, which is developed by Boston. Is a RACS score, is a risk adjustment for congenital heart surgery, is a cardiology dominated score, and they call it a RACS score 1 because the initial plan was to further develop it into RACS score 2 and 3, and they categorize the patient into 6 categories according to the difficulty, and each category is attached to certain what we call it risk of mortality and also of morbidity. Also, it's incorporate in it age of the surgery, at surgery, prematurity, and other non-cardiac structural anomalies. So risk score is a more comprehensive than basic Aristotle score, but almost equivalent even in literature to a comprehensive Aristotle score. And both are strong association in hospital mortality and length of stay. The predictive value of RACS score is higher than Aristotle basic score, and not comprehensive one. And then the STAT complexity score, which is the last one to get developed, and it's developed by the International Society of Nomenclature and Risk Adjustment in Congenital Heart Disease. And they have 5 categories. As you see, according to the type of operation, this is category number 1, number 2, number 3, number 4, and number 5. And it goes into different complexity level, and there is an expected mortality with each level. And according to this expected mortality, you compare yourself the observed mortality to the expected mortality. And this is the mortality STS operative mortality rate attached to each stat category of all ages. And then you can break it down into premature, neonate, pediatric, and adult congenital. All these can be given a certain number of mortality. And one thing we have to mention mortality, that this mortality, though it gets validated with time, but if you observe the expected mortality is coming down because of development of the business itself. The surgery itself is becoming much mature among most of the center. That plus in the United States, the regionalization of cardiac center, grouping small cardiac center into one large cardiac center, improve the result by itself and decreasing the overall STS mortality. And then multi-societal database committee have been developed. The surgeon and cardiologists realized that they cannot develop a database alone without involvement of anesthetists and health authorities and different groups from European and United States, Japanese, and others. And these all have been grouped together in a multi-society system. And this is almost now the standard. Finally, if you have the risk adjusted and you want to improve quality, we know quality is not related only to mortality and morbidity. We have a lot of issues. And finally, the International Society developed what you call it 21 quality measures, 5 structural measures, 6 process measures, and 10 outcomes measures. Involvement of a national database, multidisciplinary round, presence of mechanical support, surgical volume itself, and surgical volume of 8 benchmark operations. And this is one of the questions that we ask. These are the benchmark operations that you should compare your center to any other international center. These are VSD, TOF, AVSD, arteriosclerosis operation with intact septum, arteriosclerosis operation with VSD, Fontan, Truncus, and Norwood. And there are process measures, especially related to quality and timing of antibiotic prophylaxis and timeout, using timeout in the OR, availability and uses of intraoperative echo, either TE or epicardial echo, and regular quality assurance conference that you should develop at least once every 2 months. That's their recommendation. 10 outcome measures is requested by the International Society. This acute renal failure reporting, major CVAs, permanent pacemaker insertion, diaphragmatic paralysis, need for mechanical circulatory support, either VAD or ECMO or artificial heart, unplanned reoperation of cardiac cath, special intervention, operative mortality for the 8 benchmark operations, operative survival free of major complication, and again mortality of the or major the survival of the benchmark operations without mortality or major morbidities. In conclusion, we have now an established systems for quality measure in congenital heart disease. This passed through stages. First stage was a nomenclature and coding, and then databases development, and the risk categorization and comprehensive quality system. A recommendation, I recommend every one of you who want congenital heart disease to use IBCCC attached to ICD 11 WHO coding system, and then to use a stat risk adjustment, and also to join the world database to be one of the international affiliated centers among the world. That's the final slide. Thank you.
Dr. Abdulraoof,
Ahlan.
what does a benchmark operations mean?
Benchmark operation, when it's very difficult. As you see, we said it's almost more than 200 kind of operations. You cannot compare your center in a 200 more than 200 kind of operation to any other centers. So we should have the most common centers operation that need both skills and system to assess the quality of the center itself. And some operations, in fact, is operator dependent, like arterial switch operation. Some of them is center dependent, like Norwood. And some of them is system. Now, it's not acceptable to lose a simple VSD. Is that right?
Mm-hmm.
So you have to have a benchmark operation instead of comparing the centers in all kind of operations.
Oh, okay, thank you.
Thank you very much دكتور.
أهلا
يعطيك
أهلا.
العافية.
الله يسلمك.
ناخذ